All right, so as Chris said, most of my experience is in spinal cord injury, but I'm really excited to start on this new journey into how bladder function changes in the elderly. So today I'm going to share with you the current neuromodulation options for neurogenic pelvic dysfunction in the elderly. I don't know why it is not. There we go. So as many of us know, the elderly end up with bladder dysfunction for a number of reasons. Sometimes pelvic prolapse or prostate issues, or even muscular atrophy can lead to bladder problems. However, today I'm focusing on neurogenic bladder dysfunction. And neurogenic bladder dysfunction is any kind of bladder dysfunction that's caused by disruption between the bladder and its neural control. The symptoms typically associated with neurogenic bladder dysfunction include a loss of bladder function, an increase in urinary frequency, as well as nocturia, so having to get up in the middle of the night in order to use the restroom, sudden urgency, the inability to empty one's bladder completely, as well as various issues with leaking urine or having poor urinary force while trying to void. So when an elderly patient presents with concerns of urinary dysfunction, physicians will typically take them through a number of steps in order to give them a more definitive diagnosis and in order to determine if it is neurogenic bladder dysfunction. First, they will have them complete some questionnaires. The incontinence questionnaire short form, the urogenital distress inventory, and the incontinence impact questionnaire are the most common surveys used. Following that, they will typically undergo a pelvic exam, during which the physician will be able to determine if the patient suffers from stress incontinence or difficulties voiding completely. And in addition to that, they will typically have a urine analysis completed in order to rule out the possibility of overactive bladder being caused by urinary tract infection. In addition to that, patients will typically be asked to complete a bladder diary for up to 3 days that will include information about their fluid consumption, the number of times that they are visiting the restroom, as well as the number of urinary pads used and the number of accidents they have. Some less common diagnostic tools are urodynamic studies. These are typically used in younger patients and are not frequently used in the elderly purely because of the invasive nature of this procedure. And typically, older patients are also looked at for various mental health conditions. This can include having them complete the abbreviated mental health score or the mini mental state examination. In addition to this, many physicians will ask that their patients complete a test that gives them something called the Barthel score. And this is essentially an indication of how independent the patient is, which is really important when trying to consider treatment options within this specific population. So unfortunately, the prevalence of neurogenic bladder dysfunction is not very well reported within the aging population. And this is due to a number of factors. First off, it's very common that you do not have differentiation between neurogenic bladder dysfunction and other bladder dysfunctions in reports of urinary dysfunction. In addition to that, there's typically a lack of distinction between the types of neurogenic bladder dysfunction. So for example, you can have overactive bladder with or without leaking. You can also have stress incontinence and urge-based incontinence, all of which need slightly different treatment approaches. In addition to that, there is an inaccurate reporting of bladder dysfunction due to social stigma. It's really challenging for a lot of elderly people to admit to themselves that they're having issues with their bladder, let alone needing to consult a physician about that. Despite this, overactive bladder and neurogenic bladder is very prevalent in the aged population. In the United States, it's seen in more than 30% of those over 65 years old, and in Europe, these symptoms are seen in more than 50% of those 75 years old and over. And typically, neurogenic bladder dysfunction is more common in those assigned female at birth, and the rates in which you see this pathology increase with age. I also really want to highlight that the elderly population is growing. In 1975, those 65 and up made up only 7% of the population, whereas today they're making up 10% of the population. So essentially, I just want to highlight that this is a problem that impacts a really large group of people, and it's no surprise to any of us that it needs some significant effort on the end of researchers. So it's not a surprise to any of us that troubles with urinary health have a great impact on quality of life, both on the side of mental and social health as well as physical health. Typically, various types of neurogenic bladder dysfunction can be linked to depression. They may lead to decreased social activity due to the embarrassment or hassle of dealing with incontinence in public. This may also lead to decreased physical activity, especially in cases where people have stress incontinence. In general, bladder problems are linked to dissatisfaction with sex life and decreased sexual activity overall. And all of these factors can lead to a greater instance of institutionalization due to an increased need for care. This is especially prevalent in individuals that struggle with day-to-day tasks. And according to Medicare, roughly 33% of those over 65 are struggling with day-to-day tasks. So this means that a lot of people are finding themselves reliant upon the care of others in order to make it through their regular daily lives. Neurogenic bladder dysfunction in the elderly can also have an impact on physical health. There's an increased risk of falls, especially in cases where there is urge incontinence or an increased incidence of nocturia, as people are getting up in the middle of the night and rushing to get to the restroom. There's also an increased risk of urinary tract infection, skin breakdown, and skin infection due to challenges keeping their genitals dry, as well as bowel problems. Neurogenic bladder dysfunction can also complicate the treatment of current other problems that individuals may be having, such as prostate issues or issues with pelvic organs overall. So in addition to a pretty large impact on quality of life, overactive bladder in the elderly population does have a significant financial burden. In a study that was performed by Cisternas et al. In 2009, individuals on Medicare Part D were collected and were broken into two groups, those that had overactive bladder and those that did not have overactive bladder. All of these participants were age matched, and they were all over 65 years old. By the end of the study, they found that those with overactive bladder were nearly twice as costly in comparison to those without overactive bladder. And I do want to highlight that this is only referring to any of the instances in which the patients are seeing physicians or are getting treatment at a medical facility. This does not include the copays associated with medications. It doesn't include the cost of urinary pads and cleaning supplies and that sort of thing. So once an individual has been officially diagnosed with neurogenic bladder dysfunction, physicians will take them through a number of treatments in order to try to remedy their symptoms. First, they will typically stay with something that's more conservative. So they'll try behavioral management or physical therapy for pelvic floor health. Some of the types of behavioral management could include a decrease in fluid intake or being very specific with fluid consumption timing. Some individuals will be asked to catheterize, especially if they're having issues with completely emptying their bladder. Some individuals will need to stick to specific toileting times. Some people are asked to wear compressive stockings during the day. And also many people are asked to avoid bladder irritants such as coffee and seltzer water and alcohol. Now, in cases of mental decline, the application of these options requires a highly involved and attentive care team. So unless the patient has that available and they're very, very independent, it's unlikely that these conservative factors are going to work because it's going to be very tricky for them to stick to these regimens. If the conservative interventions are not impactful, they'll then move on to pharmaceutical interventions. The two most common interventions are treatment with anticholinergic medications and treatment with antidiuretic hormone. Anticholinergic medications work by decreasing the parasympathetic input to the detrusor muscle, thus decreasing bladder contractions and decreasing the symptoms associated with overactive bladder. Antidiuretic hormone works by decreasing urine production. However, it's important to note that this is not safe for individuals with any sort of edema or hypertension. Pharmaceutical intervention does pose a significant risk with the side effects that are associated with these medications, especially in those that are considered the frail elderly. With anticholinergics, patients may experience dry mouth, increased chronic constipation, increased confusion, and increase in dementia-like symptoms, which is particularly concerning in the aged population. If conservative and pharmaceutical treatments don't work, they then move on to mildly invasive treatments. The first treatment I'm going to talk about is the use of onabotulism toxin A. This is administered directly to the detrusor muscle and essentially works by decreasing activity and contractile force within the detrusor, thus lowering the symptoms associated with overactive bladder. However, I do want to point out that in many cases, patients need to return to clinic to get repeat treatments with onabotulism toxin, typically every 6 to 12 months. And some patients need to then rely on catheterization in order to fully empty their bladder, which is a pretty big issue in some of the elderly population, as they may be lacking some of the dexterity required to use catheters. And then the other type of intervention is electrical neuromodulation, and that's what I'm focusing on today. The two primary types of electrical neuromodulation used in the elderly population are sacral nerve stimulation and tibial nerve stimulation. Those are going to be my focus. However, I do also want everyone to know that spinal cord stimulation and sometimes stimulation of the dorsal genital nerve dorsal genital nerve is also an intervention that's not frequently used, but is out there. So before we can really get into the use of neuromodulation, I do want to just go over the basics of how a healthy bladder works. In order for someone to have appropriate voiding and storage of urine, you need to have a very delicate balance between the autonomic nervous system, comprised of the sympathetic and parasympathetics, as well as the somatic nervous system. In this specific circuitry, the sympathetics are communicated from the spinal cord to the bladder via the hypogastric nerve, which is going to inhibit detrusor contraction and also increase contraction in the external urethral sphincter in order to store urine. Conversely, the parasympathetics are going to travel via the pelvic nerve to the bladder in order to increase detrusor contraction and relax the external urethral sphincter in order to trigger voiding behavior. In order for the system to work, you absolutely need sensory feedback. All of the sensory information from the bladder is traveling via the pudendal nerve and also travels up the spinal cord via Lisenauer's tract to the various structures in the brain that determine whether it's appropriate to void at any given time. Without sensory function, it is really tricky to get this circuitry to work. I do also want to highlight that the external urethral sphincter and pelvic floor are the only parts of the lower urinary tract that have volitionary control. And that is very important to note when considering various types of degeneration and injury to the system. So what's happening when we have neurogenic bladder dysfunction? We essentially have breakdown of the circuitry. So if you have a higher level spinal cord injury or higher level degeneration, you're going to end up with a disconnect between the supraspinal centers and the spinal centers that control for lower urinary tract function. This means that you're likely going to have challenges with volitionary nutrition, and in some cases, it may not be possible. If you end up damaging the sympathetic control of the lower urinary tract, you'll end up with a system in which the detrusor cannot relax properly, meaning that that individual may be more likely to have symptoms associated with overactive bladder. And then finally, a damage to the sacral spinal cord, which houses the parasympathetic and somatic aspects of the control of the lower urinary tract, may result in a weak or non-existent detrusor contraction, as well as an inactive external urethral sphincter, meaning that some of these patients may end up with a flaccid bladder and uncontrolled urine leaking. So what I wanted to highlight with this is that neurogenic bladder dysfunction and the symptoms associated with it are largely dependent upon where the injury or degeneration is occurring within the system, and also the extent of injury. And this means that there's a great heterogeneity when trying to treat individuals with neurogenic bladder dysfunction, especially those that are aging. So how do the elderly specifically develop neurogenic bladder dysfunction? There's been a lot of research looking at aging-related degeneration, and this is just a brief highlight of some of those instances. But some scientists have found that there's a decrease in postganglionic sympathetic and parasympathetic neurons, meaning that there is less of an effect on the bladder in general. They've also found that there's a decrease in sympathetic innervation in the major pelvic ganglion, which is the peripheral control of pelvic function. They've also found that there are changes in the sensory innervation, both in the bladder and bowel. And one particular study that I found very interesting found that there was also a decrease in activity in structures in the brain associated with maintaining continence in the elderly during urge-based incontinence episodes. So there's a lot of change going on here. This gets even more complicated if someone is dealing with a disease or trauma. So traumatic spinal cord injury, traumatic brain injury, Parkinson's disease, multiple sclerosis, stroke, and spinal tumors can all make this situation quite a bit worse. So if you already have destruction of the circuitry because of one of these diseases, and then you're adding this slightly slower degeneration that happens as a result of aging, it makes it incredibly challenging to treat neurogenic bladder dysfunction. And I want to highlight that all of these factors really lead to a great heterogeneity, both in the cause and presentation of neurogenic bladder dysfunction. And this really highlights the need for individualized healthcare in these cases. So what about neuromodulation as an intervention? Neuromodulation is an approach that targets or disrupts the activity of specific populations of neurons that are dysfunctional using electricity. And what's nice about neuromodulation is that it works with the existing circuitry. So if someone has an injury, for example, higher up in the spinal cord, and they are not having any disruption of those sacral spinal centers or the sympathetic innervation of the lower urinary tract, you can essentially hijack that circuitry with the use of neuromodulation to get it to do what you want it to do. Neuromodulation can also be used in conjunction with less invasive interventions. So there is a lot of success in patients that use various pharmaceuticals along with neuromodulation. And neuromodulation is also highly adaptable. So you can change the amplitude, pulse width, frequency, and burst patterns that you're using to stimulate with. And this is sort of getting at that benefit of having individualized healthcare. Neuromodulation also has the ability to be multi-purpose because many of the circuitries in the lower urinary tract are also shared with the bowel and with a large portion of the circuitry for sexual function. You're able to sometimes do double duty in that case and help someone with both urinary function and with bowel function. So the exact mechanism through which neuromodulation works is not very well understood. However, there are many theories about what is going on a neural level. Some of the most common theories are that you are changing the threshold for action potential in specific groups of neurons, meaning that they either need more input or less input from upstream neurons in order to be activated. In some cases, you are increasing or down-regulating the release of glutamate or GABA into postsynaptic neurons that can change the excitatory postsynaptic potential or the inhibitory postsynaptic potential. You may also have an upregulation of various voltage-gated channels in order to change the refractory period in certain neurons. Regardless of how this is working, we do have some good evidence that neuromodulation is a good intervention for those suffering with neurogenic bladder dysfunction. So to start with, I'm going to talk about sacral nerve stimulation. This is an FDA-approved intervention for bladder and bowel dysfunction, and there are 2 devices that are currently available for implantation. The Axonics device as well as the Medtronic InterStim are the most commonly used devices. This works by placing stimulating electrodes so that they sit on the S2 through S4 nerve roots. And it works by either modulating the afferents that are coming from the bladder to the spinal cord or by modulating the parasympathetic influence on the lower urinary tract. In this case, a stimulation is typically applied continually at submotor threshold at a frequency between 5 to 20 hertz. For the implant procedure, it's relatively simple. It's an outpatient surgical procedure and it's under general anesthesia. The patient will first be placed in the prone position and a foramen needle is then used to find the S3 foramen. Once it is verified that the needle is correctly through that S3 foramen, they're able to thread a tined electrode lead through that needle so that it rests against the S3 nerve root. The position of the tined lead is determined with the application of electrical current in the OR. So typically they will see reactions such as toe movement or the bellows reflex in order to confirm that the position is correct. And in some cases, they will even wake patients up very briefly to see if they're having any sensations associated with the stimulation of that S3 nerve root. What's really nice about sacral nerve stimulation is that patients are able to undergo a test phase before they have a pulse generator permanently implanted. So the patients will have just the tined electrode along with an external pulse generator for about 2 weeks. And then if they see a 50% improvement of symptoms during that 2-week test phase, they will then go through with the implantation of the pulse generator as well. Approximately 40% of individuals that undergo this initial test phase will progress onto permanent implants. So in order to qualify for sacral nerve stimulation, it's recommended for patients that have refractory non-obstructive urinary retention, urgency, urgent incontinence, and severe frequency episodes. And typically it's recommended that these individuals have a failed response to behavioral modifications and pharmacotherapy for over 8 to 12 weeks before progressing onto this slightly more invasive intervention. This is not a good fit for those that have urinary obstruction, urinary infection. Patients with fast-moving neurodegenerative diseases are also not recommended this intervention. It's also not great for patients that are receiving diathermy or ultrasound, and it is also not advised for those that need to undergo regular MRIs, as many of the devices, unfortunately, are not yet MR compatible. And then I just wanted to highlight one paper that looked at the success of sacral nerve stimulation in an elderly population. In this paper, published by Angioli and colleagues, they took 18 women that were over 65 years old with urgency urinary incontinence. All of the patients underwent the initial test phase of sacral nerve stimulation, and then 15 out of 18 underwent the permanent placement of a pulse generator. These patients were then all followed up with a year post implantation to see what their symptoms were. And it was found that 83% of the patients that received a permanent implant exhibited greater than 90% of a reduction in symptoms, and nearly 30% of patients received or underwent an improvement of 50 to 90% of a reduction in symptoms. And these changes are really seen all across the board. In general, at 12 months post-implantation, people have a decrease in incontinence episodes, a decrease in the number of urinary pads used, a decrease in voiding frequency, and a decrease in nocturia. These patients were also asked to complete a questionnaire to examine overall quality of life. And it was found that implantation and use of this device had a very significant improvement in quality of life. And this as well is across the board, where people had a decrease in symptom severity, they had an easier time coping with things, they had less concern, they had improved sleep, and they also had improved social lives. So showing that sacral nerve stimulation is a feasible option for those dealing with neurogenic bladder dysfunction in the aged population. Some of the most common adverse effects that are fortunately relatively uncommon include an undesirable change in stimulation. So if the device malfunctions, again, which is very uncommon, some people may experience implant site pain that typically ends up correcting itself within a couple of weeks. Very rarely you'll have cases of lead migration or dislodgement. You can have instances of implant site infection, and sometimes stimulation will cause unpleasant or unplanned changes in bladder, bowel, or sexual function. I also want to highlight that typically the pulse generators need to be replaced every 5 to 10 years, depending on the stimulation intensity and the specific device being used. However, the lead itself is able to stay in place if that is functioning correctly. The other type of neuromodulation that I'm going to speak about today is tibial nerve stimulation. And this uses electrical stimulation to target the posterior nerve of the tibial nerve, either percutaneously or with an implant. And this can be used to treat overactive bladder, fecal incontinence, and chronic pain. And there are currently several implantable devices that are FDA approved. Tibial nerve stimulation is sort of different in the sense that it consists of 12 weekly sessions that are 30 minutes each, in which people are undergoing stimulation. So this is not an ongoing treatment. And this works by targeting the posterior tibial nerve that originates at the L4 through S3 nerve roots, many of which are shared with the innervation of the lower urinary tract. So tibial nerve stimulation can be done either in office or with an implantable device. In office, a 34-gauge needle electrode is placed at the ankle close to the posterior tibial nerve, and a surface electrode is placed in the arch of the foot in order to behave like a return electrode. And stimulation will be provided for 30 minutes at 0.5 to 9 milliamps at roughly 20 hertz. In some cases, this can also be performed using only surface electrodes. In this case, it's referred to as transcutaneous tibial nerve stimulation, and this is more commonly used in the elderly as it is the least invasive way in which you can use neuromodulation. With the implantable devices, they are still outpatient procedures, and they're done under localized anesthesia. Typically, a small incision is made on the lower leg, and then a blunt dissection is used to create a pocket on the deep fascia and the posterior tibial nerve. The stimulator is then implanted and held in place with suture, and the incision is closed. Similar to what is done in clinic, the stimulation is provided for approximately 30 minutes weekly, and this can be done at home wearing an external battery pack as shown below. So the requirements for tibial nerve stimulation are a little bit different from those for sacral nerve stimulation. And the primary difference here is that tibial nerve stimulation does not work in cases where people are having difficulties voiding. So it works really well for the treatment of overactive bladder. However, it does not seem to be able to induce bladder contraction in instances where people have problems with urine retention. The contraindications are very similar. They are not great for people with urinary obstruction or infection. It is also not recommended in people with pacemakers or implanted defibrillators. It could be risky in individuals with blood clotting disorders. And again, it is not great if someone is receiving regular ultrasound treatment. I do want to highlight, though, that tibial nerve stimulation is a great intervention for people that need to have regular MRIs, as they don't need to worry about a device being MR safe if the treatment is only being done in the office. So there were very few papers that looked at tibial nerve stimulation specifically in the elderly population. However, I was able to find one that specifically examined transcutaneous posterior tibial nerve stimulation. In this study, 30 participants were used, 15 underwent sham stimulation, and then 15% underwent the transcutaneous posterior tibial nerve stimulation. The average age of participants was 84.2 years old, and overall, 87% in the stimulation group had an improvement in urinary symptoms compared to only 31% in the sham group. So I would say that in general, the results are less robust than what we saw in sacral nerve stimulation. However, they were still enough that it seems like a feasible intervention in this population. This group also ended up looking at various surveys in order to determine the improvement that these patients were seeing. And in general, they found that with a survey that was put out by the American Urinary Association, there was a greater reduction in symptoms with posterior tibial nerve stimulation. And that same change was unfortunately not seen in the incontinence questionnaire. So again, that's sort of highlighting that the results are not quite as robust as what we would see with sacral nerve stimulation. And the most common adverse effects in this case are bruising or bleeding at the needle site, tingling, or mild pain. And I do want to note that following the initial 12 weeks of stimulation, many individuals need to resume intermittent stimulation in order to maintain the reduction of the overactive bladder symptoms. And the implantable devices may need to be replaced every 3 to 5 years, depending on the specific device. So how do these neuromodulatory interventions compare? Sacral nerve stimulation is going to work by providing continual stimulation, and that's likely working through modulating the afferents from the bladder to the spinal cord, whereas tibial nerve stimulation is only used intermittently. So with tibial nerve stimulation, we're likely driving some sort of neuroplasticity in order to change the behavior of the lower urinary tract circuitry. Sacral nerve stimulation can be used both for overactive bladder and urinary retention, whereas tibial nerve stimulation is only recommended in cases of overactive bladder. Similar results are seen in bowel control. So sacral nerve stimulation can be used for fecal incontinence and chronic constipation, whereas tibial nerve stimulation is really only used in cases of fecal incontinence. Sacral nerve stimulation is slightly more invasive and requires general anesthesia for the outpatient implantation procedure, whereas tibial nerve stimulation only requires local anesthesia, or in the case of an in-office visit, doesn't require any anesthesia at all. Typically, sacral nerve stimulation is not recommended for those that have ongoing neurodegeneration due to the lack of MR compatibility, whereas tibial nerve stimulation is seen as safe in those populations. And then finally, sacral nerve stimulation may provide results that are more immediate in comparison to those that are undergoing tibial nerve stimulation, in which you may take up to 12 weeks in order to see a true improvement of symptoms. So the take-home message is that neurogenic bladder dysfunction has a significant impact on overall quality of life and impacts a very large portion of the aging population. The choices of treatments for neurogenic bladder dysfunction need to be made with the patient's unique circumstance in mind, as existing conditions, independence, and frailty can all play a role in whether a treatment is a good fit for a patient. Neuromodulatory interventions for bladder dysfunction have the potential to improve symptoms in those that are non-responsive to the less invasive treatment options. And despite this, it's clear that more research needs to be done on these interventions, specifically within the elderly population, in order to come to some more conclusive decisions about whether this intervention works. And then with that, I'd like to thank everyone for allowing me to speak here today, as well as my primary mentors, Dr. Grill and Dr. Jalozovic. I'd like to thank the CURE mentor PI, Cindy Amundsen, as well as the staff from the Grill Lab. And then I also have funding from Nielsen Foundation and Duke's K12 program. So with that, I will gladly take any questions that anyone has.